is parallel, but of surface over the skin for surgical procedure. That parallelogram is called as Morris parallelogram. Okay. Next, this is important. What is renal angle? What is renal angle, right? So, what is renal angle? So, what is the last rib? Last rib is the last rib is the, and you get a muscle on the back called as erector spinae. The muscle is called as erector spinae. So, this angle formed by the erector spinae and the 12th rib is called as renal angle, where you get maximum tenderness of the renal pathology. The maximum tenderness can be seen on the loin, right? Loin extends from the costal margin till the anterior superior iliac spine. So that is called as renal angle. This is called as renal angle. Renal angle. Renal angle. Now, if you take a section of kidney, the outer part is divided into a cortex and inner layers. You should know what are all the coverings of the kidney. First is fibrous capsule, paranephric pad of fat. Next is renal fascia. Next is perirenal pad of fat. So two fatty layers are present, right? The second layer and the fourth layer are the fatty layer. Fibrous layer and third layer is the renal layer. So there are four coverings for kidney. So this renal fascia is further divided into an anterior layer and posterior layer. The anterior layer is called as toed fascia, and the posterior layer is called Zugerland fascia. Zugerland fascia. Zugerland fascia. Understand? These are the coverings of the kidney. We finished already the location, slightly lower. We finished the locations. We are continuing with the Morris parallelogram. Next is renal angle. Next, covering of the kidney. The outer part is called cortex and the inner part is called medulla. If you take the blood supply, we know it is derived from renal artery, which is a branch from abdominal aorta, and the vein is renal vein. We know which testicular vein is draining into renal vein. Left testicular vein is draining into renal vein. So from the aorta, renal artery enters, which is dividing into segmental, lobar, interlobular, arch vein, interlobular, afferent arteriole. So this is the way how the renal artery is converted into renal vein. All these structures are present within the kidney. These minor ramifying branches are taking place on the kidney. What is bloodless line? So we know the kidney is divided. This is the kidney. This is the concave margin and this is the convex margin. Am I right? So whenever we do any incision over the kidney, the incision should extend only from the convex border where the blood supply is minimal. So here, that line is called as broadless bloodless line. That line is called broadless bloodless line. Next is ureter. So what is the function of ureter? It conveys the urine from kidney to the urinary bladder. The length is 25 to 30 centimeter. 25 to 30 centimeter approximately in adult. It starts from the renal pelvis. It starts from renal pelvis. Hilum, where the kidney starts. Hilum, where the ureter starts. It ends on the urinary bladder. So it shows some constrictions when it is for traversing on the posterior abdominal wall. One on the renal at the level of kidney. One where it is crossing the iliac artery. One where it opens into the interior of the bladder. So it shows three constriction. Normal constrictions of urinary bladder are three number. One at the side of the commencement, one at the level of termination. It commences within the renal calyx. We have made the calyx, minor calyx. Outer is cortex, inner is medulla. It opens on the trigone of the bladder. So it shows three constrictions. Constrictions to be remembered, okay? Where it opens into the trigone. Trigone, I will explain what. One word you remember, ureter is developed from ureteric bud. And constrictions you should remember. Three constrictions. See on the picture for IVC, right? It is right to the abdominal aorta or left to the abdominal aorta? It is right to the abdominal aorta. So formation of the inferior vena cava is right and left common iliac vein unite to inferior vena cava, which grooves the surface of the liver. Am I right? It is related to river on the caudate lobe. Am I right? Then it pierces the diaphragm through vena caval opening. Then it enters the thoracic cavity where it opens on the chamber of the heart. Right? It opens on so common iliac vein on right side and left side unite to form IVC, which lies right to abdominal aorta, pierces the diaphragmatic opening of the vena cava, which is present at the level of T10. Three openings on the diaphragm. The opening is the vena cava opening, esophageal opening, otherwise aortic opening. Aortic opening is T12. Aortic opening is T12. Esophageal opening is T8. Vena cava opening is T10. So clear. So there are three openings on the diaphragm. Diaphragm is supplied by what nerve? Phrenic nerve. It is supplied by phrenic nerve. The root value is C3, C4, and C5. So that is regarding inferior vena cava. Finally, inferior vena cava opens on the right heart. Now proceeding with the pancreas, which has head, neck, body, and tail. We already finished tail. Tail is related to what ligament? Lienorenal ligament. Head is related to what structure? Second part of duodenum. So second part of duodenum, this is pancreas. Already we know there is two arteries present over here, right? Superior pancreatico-duodenal artery and inferior pancreatico-duodenal artery. So this groove present between the head of the pancreas and the duodenum is called as pancreatico-duodenal groove, which lodges superior pancreatico-duodenal artery and inferior. The groove can be, am I right? There is a space between the head of pancreas and second part of duodenum. That is called pancreatico-duodenal groove. We know neck is related to what is the formation of portal vein? It is present behind neck of pancreas. So for the neck, you remember portal vein. Can you remember second part of duodenum and anastomosis of two arteries? Am I right? And for the body, an artery runs above the body. This artery is called as splenic artery. And one fold of peritoneum is attached to the body, which is separating the abdomen into supracollic compartment, infracollic compartment. What is that? Transverse, mesocolon, transverse, mesocolon. Tail is related to what ligament? Lienorenal ligament. And hilum of which organ? Spleen. These are the relations you should remember. No other way you have to remember. Head is related to second part of duodenum and anastomosis of two artery. neck, behind the neck, formation of portal vein, and above the body, anterior artery. What is attached to the anterior marginal transverse colon and tail is related to renal ligament and tail of pancreas. Now, if you take the head like this, there is one more projection of the head coming down. That projection of the head is called as uncinate process. Uncinate process, which is crossed by superior mesenteric artery, SMA, superior mesenteric artery, the uncinate process. That to be remembered. Okay. Now see on the picture, this is the uncinate process. This is the uncinate process, which is crossed by superior mesenteric artery. Uncinate process is crossed by superior mesenteric artery. Okay. So that completes the proper abdominal structures. Next, we are proceeding with the pelvis. We didn't do bladder, rectum, anal canal, and all, right? Those are the organs that are present on the pelvis. Now we'll proceed with the pelvis. The bones forming the pelvis are ilium, ischium, pubis, sacrum, and coccyx posteriorly. Sacrum and coccyx posteriorly. And this is the inlet. This green color and the yellow color line is the pelvic inlet. This we call it as pelvic inlet. Pelvic inlet is formed by the anterior margin of the sacrum, which is otherwise called ala of sacrum, and the upper border of ischiopubic rami. That we call it as pelvic inlet. Pelvic inlet, where these structures are present: urinary bladder, uterus, rectum, and anal canal in female. In male, only urinary bladder and rectum is present, where the uterus is absent. Up to this, you are clear, right? This is a section of female pelvis. You can see bladder. This is bladder, uterus, rectum, and rectum and canal. So this is pubic symphysis. The area behind the pubic symphysis is called retrospace, otherwise called space of ribs. Otherwise called space of ribs. Now you see this. This is rectum. This is uterus. So the pouch present here is called as pouch of Douglas. Pouch of Douglas. The pouch present between the bladder and the uterus is called, what is this? Utrovesical pouch. Utrovesical pouch. Utrovesical pouch. Utrovesical pouch. So there are two pouches in female. Those are the dependent part of the pelvis. Is it clear? Next is rectum. What continues as rectum? Sigmoid colon continues as rectum. Sigmoid colon continues as rectum, which is of 15 centimeter in length. So demarcation between the rectum and the anus. Can you able to see this area? This is called recto-anal angle. This angle is called as recto-anal angle. Recto-anal angle, and it has three curvatures. As I said for esophagus yesterday, it has three curvatures. Here it has three curvature: upper, middle, lower. Upper curvature, middle curvature, and lower curvature. Upper, middle. Anything when you read rectum, lymphatic drainage, blood supply, curvature, parts, it is divided into three parts: upper, middle, and lower. The most dilated part of the rectum on the middle part is called ampulla. The end dilation is ampulla. So dilated part is ampulla, where the rectum is divided into upper 1/3, middle 1/3, and lower 1/3. Upper, middle, and lower 1/3. The upper 1/3 is made up of peritoneal layer. Upper 1/3 is peritoneal layer. Remember, peritoneum is innervating the superior surface of the pelvic organ. So it is coming only to the, only this area is invaginated by the peritoneum, whereas the middle part and the lower part is non-peritoneum. Only the upper surface and the anterior aspect, the upper one-third of the rectum is covered by peritoneum, whereas the lower part is not covered by peritoneum. On the female, the rectum is separated by the vagina by one more fascia over here. It is called as fascia of Denon Villus. Fascia of Denon Villus. Denon-Villes. Fascia of Denon Villus. Denon Villus fascia separates the vagina. This is uterus, am I right? So lower down it is vagina. So Denon Villus fascia separates the rectum from the vagina by a fascia called as fascia of Denon Villus. Fascia of Denon Villus. Fascia of Denon Villus. Is it clear? This is important. What is the fascia separating the vagina and rectum in female? And upper part, middle part, and lower part, three arteries: superior rectal artery, middle rectal artery, inferior rectal artery. Then vein should be superior rectal vein, middle rectal vein, inferior rectal vein. Superior rectal vein is portal system, middle and inferior are cable system. So if there is any portal hypertension, you get engorgement of those veins that leads to bleeding through the rectum. That is called as hemorrhoids. That is called as hemorrhoids. So the most dilated part is called as ampulla. The angle between the rectum and anal canal is called as recto-anal angle. This is the blood supply. Okay, superior rectal, middle rectal, inferior rectal. The veins are again superior rectal vein, middle vein, inferior rectal vein. Those are embedded on the muscular coats of the rectum. They ramify, then they come out into the corresponding area, into the common area vein. Next is anal. Space behind the pubis. Pubic bone, the space is called pair of rings. Anal canal. The length is important for MCQ, 3.8 centimeter, which is the continuation of rectum. The junction is called recto-anal junction, which opens exteriorly on either side of the gluteal fold as anal opening. Am I right? See the interior of the anal canal lower down. So it is situated below the pelvic diaphragm. As of diaphragm, there is one more diaphragm formed by a muscle called as levator ani on the pelvis over the outlet. The diaphragm is called as pelvic diaphragm formed by a muscle called levator ani muscle. That I show you. So remember, this line is called as pectinate line. So above this line, this is endodermal in origin. Below this is ectodermal in origin. Okay, dentate line or the pectinate line is the junction of upper 2/3 and lower 1/3 of anal canal. So whatever present above the pectinate line is endodermal in origin. Whatever present below is ectodermal in origin. Supply, venous drainage, nerve supply, everything varies between the two parts. Rectum is divided into three parts. Here it is divided by two parts: upper 2/3 and lower 1/3. Is it clear? So the upper part is developed from endoderm. So it is supplied by inferior hypogastric nerve, which is of autonomic nervous system, whereas the endoderm is supplied by inferior rectal nerve. So which area is painful? External or internal? Below pectinate line is painful. This is above is autonomic nervous system, right? You cannot feel the pain. Hypogastric plexus is above, so you cannot feel the pain. Below, so external piles is painful to the patient, or the internal piles. So whenever you to visualize the anal canal, we do proctoscope examination. By the time the positions of what are the positions of hemorrhoids? What are the three positions for hemorrhoids? 3 o'clock, 7 o'clock, 11 o'clock. There are three positions for hemorrhoids when you do a proctoscopic examination. By the time you have to look for superior rectal vein position, whenever you put the patient on the ectotomic position. Here. Now next is anorectal. Now you see the interior, you get some column here, right? This is called anal column. Anal column. Anal column. We call it as anal column. What is anorectal ring? Already I told you. It is formed by anorectal ring. See this? This is called anorectal ring. It is formed by the first muscle. What is this muscle? Puborectalis. Puborectalis. Next is deep external sphincter. Deep external sphincter and internal sphincter. This is superficial. These three muscles form a pulley around the rectum and the anal canal to hold it in position. That we call it as anorectal ring, which is formed by how many muscles? Three muscles. Puborectalis, deep external sphincter, and superficial external sphincter. So three muscles form the anorectal ring. Anorectal ring. Now you see this is the rectum, this is anal canal. The fossa present on either side of the anal canal is called as ischiorectal fossa. This fossa is called as ischiorectal fossa. It contains much abundant amount of fat. And the lateral wall of the ischiorectal fossa is called as pudendal canal. It is called as pudendal canal. It is called as pudendal canal, which is the lateral wall of the ischioanal fossa. Ischioanal fossa. After this, you are clear, right? Rectum and anal canal. So, which is painful, interior or exterior? Exterior is painful. Interior, frontal nerve, and inferior. And the hypogastric plexus will supply above the pectineal line. This one, urinary bladder. What is the location of the bladder? Behind pubic bone. That space is called space of Reeds. Space of Reeds. What is present posterior to the bladder in male rectum? What is present posterior to bladder in female? Uterus. It is uterus. Now you see, you get the opening of the ureter inside, right? It is a muscular organ and lined by transitional epithelium. The epithelium is transitional epithelium. This area of the bladder inside, this we call it as trigone. This area is called the trigone, where the two ureter open and the commencement of the urethra. This interval is called as, this triangular interval is called as trigone of the bladder. Trigone of the bladder. This is the effects of the bladder, where you get the attachment of a ligament called median umbilical ligament. This is important for MCQ. What is attached to the apex? Median umbilical ligament is attached. Again, this is the lateral surface. This is the superior surface, where you get the peritoneum above. Posterior surface is related to spinal vesicle and vas. What is related to the neck of bladder is prostate gland. This is important. Surrounding the neck of the bladder is prostate gland. It is prostate gland. So this is the median umbilical ligament. Should remember. Regarding nerve supply, what is important? Sympathetic and parasympathetic, right? So parasympathetic is from S2, S3. Have you heard of micturition reflex, filling and emptying of the bladder? So what is the muscle that of the bladder? You get a smooth muscle inside is called as detrusor muscle. The name of the muscle is detrusor muscle. So what we need nerve supply is the nerve supply to the muscle. So parasympathetic are derived from S2, S3 and S4 fibers. As the sympathetic fibers arises from T11 to L2. This you have to remember as a group with two value. Parasympathetic S2, S3 and S4 and sympathetic group T11 to L2. So clear. See on this picture. posterior to the bladder, it is uterus. This space is called rectus space. This is prostate. What is prostate? Prostate. What is prostate? It is the male accessory sexual organ which encircles the neck of urinary bladder, which encircles the neck of the urinary bladder. So, corresponding to female menopause, even male are menopause symptoms after 40. It is because of the enlargement of the prostate that compresses the urethra. So, frequent micturition can be present on a patient above 40. So, all patients with frequent urination are not diabetes mellitus. You have to look for the enlargement of the prostate. So, how you are? Either you do an ultrasound, if not, you do a biochemical assay called PSA, prostatic specific antigen, that to be traced. If the specific marker above 5, the patient will be done for prostatectomy. Okay, is going for an adenoma or an carcinoma depending upon the lobe. What I want to remember is I said adenoma and carcinoma. Adenoma is a benign one, cancer is a malignant one. So if you know the 5 lobes of prostate, anterior lobe, if you take this is the urethra, this anterior lobe, posterior lobe, a conical structure pointed downwards is the shape of the prostate. An anterior lobe, posterior lobe, two middle lobe, a central lobe where the urethra is piercing. Am I right? You can see this one, right? The urethra is piercing the prostate. Then it comes to the male component, right? For the female, urethra is very short, 4 centimeter, and the opening is 7. But for male, it traverses the corpora spongiosum. It opens on the exterior. Right? So the part of urethra what is present within the prostate is called as prostatic urethra. So this is the urinary passage. And additionally, we already know from the testis, epidermis is present. From the epidermis, is different. Then seminal vesicle present. It joins with the duct of seminal vesicle to form ejaculatory duct. That ejaculatory duct opens on the prostate. Am I right? I already told you on the posterior surface you get seminal vesicle. Am I right? It has a duct. It gives some secretions. Already vas deferens is present. So vas deferens joins with the duct of seminal vesicle to form a duct called as ejaculatory duct. So formation of the ejaculatory duct, one from seminal vesicle, others from the vas. They unite to form ejaculatory duct. This ejaculatory duct opens. You can see on the picture on the lower picture, there are 2 openings. The above opening is for the ureter. The oblique opening is for the ejaculatory duct. So how many lobes for prostate? 5 lobes. What opens on the prostate? One is ejaculatory duct. Other one is prostatic urethra. Prostatic urethra. What I am now describing is the structures that opens on the prostate. These structures are prostatic urethra and ejaculatory duct. How many lobes? 5 lobes. And you see closely there are 2 coverings, one inside and one outside. False capsule and true capsule. So there are 2 coverings of the prostate, true capsule and false capsule. So it is related to neck of urinary bladder. So anterior lobe is common for adenoma, posterior lobe is common for carcinoma. That you should remember. Which lobe is prone for? And again, when we do a prostatectomy, I said true capsule and false capsule. So the venous plexus draining the gland is prostatic venous plexus. Those are embedded between the true capsule and false capsule. So during prostatectomy, we enucleate the prostate. We leave back the capsule. We don't take the gland along with the capsule. That procedure is called enucleation. We don't do as ectomy, that we call it as enucleation of the prostate. So as to preserve the prostatic venous plexus, which are present between the true capsule and false capsule. That is very important. When you do thyroidectomy, we remove along the gland. But if you do prostatectomy, you have to scoop the glandular substance, which is made up of acini only. So those acini, like of parotid, you have to scoop out the acini particles around the membranous part of the urethra, and you have to take it out. That is the importance of, that is called enucleation. Enucleation. That is called enucleation. Next is urethra. Function of urethra. Function of urethra. Remember the difference between male and female. This is 20 centimeter in male, 4 centimeter in female. Here it has 3 parts. What is present between the prostate is prostatic part. This intermediate part is membranous part. What is present on the genitalia is called as penile part. It is called as penile part. Membranous, one is prostatic part. Second one is membranous part. Third one is penile part. So there are 3 parts for male urethra. The dilatation at this level, right? Once it is entering the male external genitalia, here it shows a dilatation. That fossa is called as navicular fossa. That fossa is called as navicular fossa. Again, you see the male urethra is opening externally on the external urethral orifice. It is opening on the external urethral orifice. So when you put a catheter inside for drainage, care to be taken, because this membranous part is the convex part. So once you put a catheter, after it crosses the penile part, gentle upload should an upright posture should be done. It comes only by practice. If not, you are rupturing the membranous part. Thereby, extravasation of urine will take place to the patient. So when you do, put like okay, slowly, gently you pull it first. It is only by practice. Rather than doctors, the nurses are well trained on catheterization. Membranous with a rupture, very common. So, there will be an pull outside when you rupture the membranous urethra. So slowly you put the catheter when you do the catheterization. That is very important. Second part should not be ruptured. So this fossa is called as navicular fossa. So prostatic urethra is the widest part. Which part of the urethra is widest? Prostatic urethra. Which part of the urethra is least dilatable? Membranous part. 2 things you remember. Widest urethra is prostatic part. Least dilatable part is membranous urethra. Membranous urethra. What is this muscular mass we call it as? Corpora cavernosum. Corpora cavernosum. Remember, whole of the external genitalia of the male is formed by the erectile mass. Remember, abundant amount of blood supply is present in this area by through corpora spongiosum and corpora cavernosum. Corpora spongiosum and corpora cavernosum. Female urethra is long or short? Short, it is lined by transitional epithelium. That's the reason why again urinary tract infections are common to female. Shorter urethra, shorter pelvis. Male has wider pelvis, longer urethra, so the infections are not common. Moreover, the peritoneal cavity on male is a closed one, whereas in female it is an open one. Am I right? Because the fallopian tube is an open one, right? It needs the ovary to be fit during menstrual cycle. So it has an opening on the ampulla. So that area is open. So any pelvic infection or any uterine infection, vice versa, it can retrogradely pass the fallopian tube. So these are the difference between male. Three difference: shorter urethra, shorter pelvis, pelvic cavity is open. Where it opens on the fallopian tube. That is the area where the tube is open. Next is fallopian tube. Layers of scrotum, did I explain? Layers of scrotum. Layers, your testis we finished. Alright. Layers are skin, dartus muscle, external spermatic fascia, cremastic fascia, and internal spermatic fascia. There are 5 layers of scrotum in order from outwards to inwards. The layers are skin, dartus muscle, external spermatic fascia, cremastic fascia, and internal spermatic fascia. The erection of the penis is through which nerve? Parasympathetic fiber, nerve S2S3S4. Direction of the penis. These are all in MCQs. Nerve erythritans, ERGIGNDS. The root is S2, S3, S4 fiber. Nerve erythritans. Next, parts of fallopian tube from lateral to medial. This dilated part is called as ampulla. On the ampulla, you get something called as fimbriae. Next, this is ampulla. This fimbriae, infundibulum, ampulla, isthmus, intramural part. What is present within the uterus is called as intramural part. These are the parts of fallopian tube. Fallopian tube is lined by pseudostratified ciliated columnar epithelium. The function of the fallopian tube is to convey the ovum from ovary to the uterus for normal menstruation. Normal menstruation. So, what is the site of fertilization? Ampulla of the fallopian tube. Ampulla of the fallopian tube. The part of the peritoneal fold connecting the fallopian tube to the ovary. This area is called as mesosalpinx. Mesosalpinx. Mesosalpinx, which contains apophoron, which is the embryological remnant. Apophoron, which is the embryological remnant. This is the apophoron. So, what is the critical importance of if the pregnancy is on the tube, it is called as tubal pregnancy. It is called as tubal pregnancy. What is the radiological investigation we do to see the patency of uterus and fallopian tube? That is called hysterosalpingography. 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 Inject a dye where it can on the vagina and uterus. Here it is patent. The dye has fallen down onto the right side pelvic cavity. This is a normal one. The dye is on the pelvic cavity on the left side. Hysterosalpingography. Regarding uterus, what are all the parts of uterus? Fundus, body, cervix. Fundus, body, and cervix. What is present anterior to the uterus? Bladder. What is present behind? Rectum. What is the pouch in front of the uterus? Front pouch. What is the pouch present behind? Pouch of Douglas. What is the function of fundus? That is the area of where the area zygote is implanted. Posterior wall of fundus. Be specific. You should not write fundus. It is wrong. Posterior wall, that is the normal side. Posterior wall of fundus of uterus is the normal side of implantation. Is it clear? Now what is cervix? The lower neck, the constricted part is called as, it is called as cervix. Now you see the vagina is invading into the anterior wall that divides the cervix into a supravaginal part and a vaginal part. So these are the two parts of cervix, supravaginal and infravaginal. So if it goes info like this area you get some space, right? This we call it as fornix. We call it as fornix. This area we have anterior fornix, posterior fornix, and lateral fornix. There are three fornix that are present in relation to the cervix. And inside the cervix, you get this kind of cervical canal on a fusiform manner called as arbor vitae. That arrangement is called as arbor vitae. First, you know the parts of the uterus, its location, its relation anterior, posterior. What is the organ anterior? What is the organ posterior? What is the pouch in front? What is the pouch behind? Then what opens on the uterus? Fallopian tube opens on the uterus, and the function of the fundus for the site of implantation, and this mucous fold are called as arbor vitae. Arbor vitae. How the folds are kept in position by means of supports. Few structures hold the uterus in position. Right? What occurs in pregnancy? How many times the uterus enlarges in size in a female? It is of 7 centimeter length organ. How many times it expands during pregnancy? 2.5 to 3 kg of a child during amniotic fluid, placenta, umbilical cord, right? So approximately 5 kg weight of a female has been added into a 7 kg weight female of a uterus. So how far it enlarges? How far it enlarges? How many times? 100 times. It is coming. It is a smaller organ, 7 centimeter and longer. It is on the pelvis between bladder and rectum. But we read the fetal position, right? It is coming till this term, right? And second term, third term again it go back to the normal, right? Right till the sternum, the uterus come. After delivery, again it comes back to its normal position in another 2 or 3 days. Correct? So that much the musculature of the uterus keep on expanding, giving space for the fetus to its normal environment. Right? It is the utmost beauty present for an female. Right? Again it comes back to its normal. The female is attaining a normal menstruation again. Alright? So for that you need support to maintain it in a position that we call it as supports. One is the angle formed by the vagina and the uterus. Then the angle formed by the fundus and the body. First is angle. The angle formed by the uterus and vagina, anteflexed. That maintains the normal support. Next, fundus and body, anteverted, anteflexed, anteverted. You remember, anteflexed. So angle is the first support. Second support, pelvic diaphragm. What is below is pelvic diaphragm. Now you see the ligaments. Transverse cervical ligament, right? Extending from the cervix laterally. This ligament is called as transverse cervical ligament. Pelvic diaphragm is a part of levator ani muscle, which is the next support. Next is uterosacral. Uterosacral. sacral, pubo-vesical. So all these ligaments maintain the uterus on the position. The elasticity of this ligament fibrous tissue, right? So the elasticity will be lost on an individual female as age advances, and on multiparous women the elasticity is lost. That's the reason why the prolapse of the uterus is common. We know first degree, second degree, third degree, and you know to proceed with hysterectomy. It is because of this ligament elasticity. I said pelvic diaphragm, right? Which is formed by a muscle. See on the picture, pubic symphysis, right? Are encircled by muscles, right? To keep the structures of the position, we have a tendinous lower down muscle called as pelvic diaphragm. Pelvic diaphragm. Levator ani is the pelvic diaphragm. Levator ani is the pelvic diaphragm, which has pubo-coccygeus part and ilio-coccygeus part. There are two parts for pelvic diaphragm. Levator ani muscle, one single muscle, which has what are all the parts? Pubo-coccygeus and ilio-coccygeus. This is pubo-coccygeus proper. This is ilio-coccygeus. This is piriformis. This is coccygeus. All this muscle make a sling bilaterally, which origin from the ischiopubic rami and inserted over the sacrum and the coccyx. Am I right? That is pelvic diaphragm. Pelvic diaphragm. Can you able to see this? Levator ani. This is ilio-coccygeus. This is pubo-coccygeus. Pubo-rectalis. Pubo-rectalis. Coccygeus. All this muscle make a sling on the inferior aspect of the pelvis that we call it as pelvic diaphragm. What we do during normal labor? Internship is over for you people. Internship. Yes, right. You will be posted on obstetrics on the clinical rotation. Have you seen normal labor? One normal labor at least. Not it. Not at 10, right? What we do, normal labor. Yes, what we do during normal labor? We do episiotomy. Beyond that, what we do? As first line, we do defecate the patient, right? We give enema, we do symptom, we start the case. Then we do pelvic diaphragm support, right? That's the work for the intent, right? On a normal ward, what the PG will be doing the episiotomy. What the intent usually we do is we have to sit with a stool and you have to give pelvic support to the female, not to tear. Unless otherwise, pelvic diaphragm may be torn. Am I right? The pressure what the female give depends upon her strength by the time what she has. She tries the maximum to push the child out, depending upon whether the head is coming or the hand is coming. That God decide whether it is a bridge presentation or an abdominal presentation. But what we do is we at most try to preserve the pelvic diaphragm, not to tear. At most, at one end there can be some tear thereby because you see on this picture the pelvic diaphragm is pierced by so many structures, right? Vagina, rectum, urethra. All three major structures are pierced in the pelvic diaphragm. Urogenital diaphragm is present below that should not go for rupture. That's the reason why we give pelvic support. This is the routine what we do in normal side. Only the postgraduates will be allowed to do normal labor. We give some chance to do episiotomy and pre-suturing. Beyond that, the intents have to sit holding the pelvic diaphragm in grip till the labor is over. That is the duty of an intern. What we do here. Next is perineum. What is perineum? Perineum. The area between the external genitalia and the anal canal. That area is called as perineum. That area is called as perineum. What is urogenital diaphragm? Urogenital diaphragm. It is formed by two muscles, urogenital diaphragm. Pelvic diaphragm is different. This is urogenital diaphragm which is formed by two muscles, urethra and deep transverse perineal muscle. This triangle is called as urogenital diaphragm. This is the ischial tuberosity. What is present anteriorly to this triangle is urogenital triangle. This is external genitalia. This is anal canal. This area is perineum. The area between the external genitalia and the anal canal is called as perineum. Where a triangle is present. If you draw a line in front of the ischial tuberosity, that area is called urogenital triangle, which contains urogenital diaphragm, which is formed by two muscles, sphincter urethrae and deep perineal muscle. Pouches, superficial perineal pouch, deep perineal pouch. Little difficult to understand. I'll tell you the location content. To understand this, you need some more imagination of the exact pelvic architecture. So I don't want to go with the details. Just you know the boundary and what are all the content. Okay. Above by perineal membrane, that is nothing but the urogenital diaphragm, fascia pole, and behind by the fusion of these two membranes. That area we call it as superficial perineal pouch. Now this is the perineal membrane, which is attached to the inner surface of the ischiopubic rami and to the ischial tuberosity. This body is the perineal body. 10 muscles are to perineal. Remember, how many muscles? 10 muscles are attached to the perineal body. These structures piercing the perineal membrane are the total nerve, middle artery of penis, dorsal artery of penis, urethra, duct of bulbourethral gland, and vagina in male. These are structures that pierces the perineal membrane. The content of this superficial perineal pouch, content of the superficial perineal pouch. This is the boundary. You should know what is the content of the each pouch. Superficial perineal pouch, what is the content? Deep perineal pouch, what is the content? Superficial transverse perineal muscle. Four structures now. Superficial perineal pouch content. In the main, there is no content. Because content will be asked in MCQ. What are all the content except at least you memorize superficial perineal pouch content, deep perineal pouch content. Superficial transverse perineal muscle. Next is bulbospongiosus. Ischiocavernosus. One gland, Bartholin gland. Remember SBI. Next SBI. Sphincter transverse perineal, bulbospongiosus, ischiocavernosus, and Bartholin gland. So that is the content of superficial perineal pouch. And this is the deep perineal pouch, and the content are this is important. Dorsal nerve of penis and dorsal nerve. This is important. Dorsal nerve of penis and dorsal nerve of clitoris. So, what is the artery of the pelvis? Internal iliac artery, which is the branch of common iliac artery. Right? Common iliac artery divided into external iliac artery and internal iliac artery. This internal iliac artery is further divided into an anterior division and posterior division. Anterior division and posterior division. The anterior division gives off superior vesical artery, which is marked as number 1. Superior vesical artery. Middle vesical artery. Inferior vesical artery, which is marked as 3. obturator artery to middle rectal artery. So what has been marked over here, right? 1 to 7. These are the branches of anterior division of internal iliac artery. 7 branches are given out from the anterior iliac artery, of which vesical artery are supplying bladder. Obturator artery is going to the medial compartment of the thigh. Superior gluteal, inferior gluteal is going for gluteal region for gluteal anastomosis. Internal pudendal artery is entering the pudendal canal. Pudendal canal is otherwise called as Alclox canal. The canal is otherwise called as Alclox canal. Posterior division gives of the branches are superior gluteal artery, iliolumbar artery, and lateral sacral artery. These are the branches of the posterior division of internal iliac artery. So anteriorly, how many branches? 7 branches. On posteriorly, 3 branches. So this is how to remember. A 17-year-old boy suffers a trauma groin injury during a soccer match. The urologist noticed tenderness and swelling of the body, left testicle that may be produced by thrombosis in which of the following vein? Testicular vein drains into, this is on left side, left renal vein. The answer is renal vein. 59-year-old woman comes to a local hospital for cancer surgery. As the uterine surgery passes from internal iliac artery to the uterus, it crosses which of the following structures which can be ligated during such surgery? Answer is one structure is crossing. Normally, step terminate, that is the first step. You should not disturb the ureter. Clear, as the post-surgical complication, there will be dribbling of urine in restricted patient. That represents the obstruction is not a drained one. And there is not any dribbling. That represents you have disturbed the ureter. Because we know ureter is on the kidney, it has abdominal part, pelvic part, it has 3 segmental nerve supply. So care to be taken. Again, the ureter will be passing between the sigmoid mesocolon, which is attached towards the sigmoid colon. It is entering into the sigmoid colon. So care to be taken not to move the ureter more than half an inch during surgery. Beyond that, you should not move. If you move that, you are disturbing the nerve supply. So it is ureter. 20-year-old woman is admitted to the hospital because the birth of a child is severe days overdue. Hearing of the following diaphragm during childbirth leads to paralysis of which of the muscle? Levator benign. An elderly man with benign enlargement of his prostate experienced difficulty in urination, urinary frequency and urgination. Which of the following lobes of the prostate is completely involved in benign hypertrophy that obstructs posterior urethra? Be specific. Anterior is common for hypertrophy, but it is compressing the urethra. It is compressing the urethra for frequency and urgination. Enlargement is okay, but they didn't do whether it is an benign enlargement. Anterior. More specific, anterior, and it is middle lobe, because middle lobe is encircling urethra, neck of urethra, right? On the center there is one more part. If there is no option for the middle, it is anterior. Here the middle has been given, so it is middle lobe. A 35-year-old man comes to local hospital with abdominal tenderness and acute pain. On examination, a physician observes that an abdominal infection has spread retroperitoneally. Which of the following structure is mostly infected? The physician observes that an abdominal is retroperitoneum. Stomach is covered by peritoneum. Transverse colon is covered with peritoneum. Spleen is covered by peritoneum. Jejunum is covered by peritoneum. Descending colon is not our, it is an retroperitoneal organ. Here we have greater momentum, lesser momentum. Here transverse mesocolon. Here renal ligament, tendinocortical ligament, gastrocolic. So the answer is descending. So with this, I complete the abdomen and pelvis. The development and histology of this is pending that we will do later. Separate course. Next, we will continue with lower. Break. Break away now. 2 minutes break. But I don't know. 145 then open. No. Finish try. Lower and one. Full and compare பண்ணி அப்படியே சொல்லிட்டே போறோம். நீங்க தான் ஆன்சர் பண்ணணும். So proceeding with the lower limb, know the general architecture. The regions are thigh and leg, thigh, leg, and foot. Whereas on the upper limb it is arm, forearm, and hand. Correct. So on the arm we have two compartments: flexor compartment and extensor compartment. And we have two compartments. Likewise, on the thigh we have anterior compartment and medial compartment. Whereas on the leg we have posterior lateral compartment. Additionally, lateral compartment. Here we call it palm and dorsum. There we have dorsum above, the plantar below. Plantar below. And I said pre-axial border and post-axial border. Radius and ulnar is reverse, right? So lower limb develops from the limb bud, right? The limbs are developed from the limb bud and upper limb bud and the lower limb bud, which is supplied by the lumbosacral trunk, L2-3 fiber but inner way. So the great toe is positioned on the cephalic direction with the sole of the foot in anteromedial direction. That's the reason here it is post-axial and pre-axial border. Here there is a controversy between the right limb and that's the reason why the flexors on the arm, here it is extensor, just opposite. Flexor compartment of arm, flexor compartment of forearm, flexor of arm, sorry, extensor of arm, extensor of Here it is not so. Flexor are posterior, extensor are anterior. Again, medial compartment is addition with the adductor compartment. That is called as adductor compartment and the lateral compartment. Again, likewise, here we have two retinaculum, flexor retinaculum and extensor retinaculum. There we have three retinaculum, flexor, extensor. One for the lateral compartment, it is the peroneal retinaculum. Peroneal retinaculum. So three retinaculums are present. Here the carpal bones are 18 in number. There the dorsal bones are 7 in number. 7 in number. You have to less one bone. Here it is 8. There it is 7. Okay, this is how the limb is rotated, right? How the fetus is present on the mother's. What is that position called as? Uniform flexion. Uniform flexion. Am I right? The head is flexed. Hands are flexed towards the chest. Thighs are flexed towards the trunk. Am I right? It needs space. Though the mother is giving 100 times enlargement, the child at most tries to accommodate a smaller space, allowing amniotic fluid and placenta to grow well for its nourishment. So it's universal flexion. Universal flexion. Am I right? So dermatomes. This is you are aware of it, right? Segmental innervation. For upper limb you did, right? T4, T5, C6, C7, T8, sorry, T1 and T2. Likewise for the lower limb. You should remember for the great toe L4, for the toe it is S1. L1, anterior part of the thigh L2, L3, over the patella on the leg L4, L5, over the dorsum L5, S1, all three nerves are right. L5 is descending down, right? The fiber, the venous innervation is descending down on the this is on the anterior aspect. So dorsum of the foot, three nerves. Towards the toe, it is towards the great toe, it is L4. Violet color, man. This violet color. S2 is posterior. This is L4, L5, S1. L4, L5, S1 for the dorsum. L4, S5, and S1 for the dorsum. Over the gluteal region, you will be having superior gluteal nerve S1, S2, S3, S4, 5.